Hello everybody, my name is Dr. Matja Jurgevik and I'm an anesthesiologist at the County General Hospital, Dr. Josip Benčić in Slavonski Brod in Croatia. And the topic of my lecture today is, can we protect the lung while at the same time protecting the brain? This is my conflict of interest. So what are the classic things we know about brain injured patients in the intensive care unit? Well, first of all, we know that a traumatic brain injury is the most common cause of death in people under 40 years of age. And we also know that the cerebral vascular disease is the leading cause of mortality and disability, and that acute neurological disorder is the principal indication for invasive mechanical ventilation in around 20% of the cases. And what is the most important thing is that we know that neurologic patients have longer periods of invasive mechanical ventilation regardless of the underlying pathology, whether it's traumatic brain injury, stroke, subarachnoid hemorrhage, etc. Now, the brain-lung crosstalk is a complex interaction from the brain to the lung, but also from the lung to the brain. The pathophysiology of lung injuries after an acute brain injury is still in debate, and several theories have been proposed. One of the most popular is the so-called double hit theory. This means that a systematic inflammatory response appears to play a major role in the development of acute pulmonary failure after acute brain injury, but also that the acute inflammatory response in the lung leads to secondary brain damage. Now, the pathophysiological process is the intracranial inflammatory response that occurs after brain injury, with pro-inflammatory cytokines being released and produced locally in the cerebral injured tissue. Then, with the alteration of the blood-brain barrier, permeability allows their discharge into the systemic circulation with transcranial gradient. This could be responsible for the extracerebral dysfunctions. The systemic production of inflammatory mediators constitutes an inflammatory environment to the so-called first hit theory. Organs are therefore more susceptible to the subsequent events, namely the second hit, such as mechanical ventilation, infection, or surgery, that could in normal conditions be relatively harmless if performed lung protectively. However, this inflammatory cascade does not occur only in one brain, from the brain to the lung, but also from the lung to the brain. So two components may be involved in this lung-to-brain pathway. Lung injuries as themselves, such as acute lung injury or ARDS, and of course mechanical ventilation. For example, in the study by Quiles on high tidal volume versus low tidal volume in rats, it has been shown that inflammatory response in the retrosplenial cortex and thalamus were higher in the high tidal volume group than in the low tidal volume group. So it's a complex interaction that works in both ways, and any damage or inflammation to one organ can cause a damage to the other and vice versa. So now we know that most of what we call lung protective ventilation, optimizing mechanical ventilation, comes from mechanical ventilation in ARDS. And this is, for example, the classic things like low tidal volume ventilation or limitation of the plateau pressure. Then, of course, optimizing, individualizing the PEEP, mining, of course, the driving pressure. Recruitment maneuvers, yes, when they are applicable, no, when they are not. Spontaneous breathing, yes, when it's safe, no, when it's not safe. Specific ventilation oxygenation goals that are a bit different in severe ARDS than are in basic physiology. And of course, some major things like measuring of the transpulmonary pressure and adjusting mechanical ventilation to the transpulmonary pressure, use of prone positioning, and of course, if everything else fails, then it's the CCT2 removal or the ECMO. So now, with the complexity of brain-lung interactions in mind and the influence of mechanical ventilation both on the lung but also on the brain injury, how can we optimize mechanical ventilation for both brain injury and the lung? There are some recommendations from the European Society of Intensive Care Medicine published in 2020. There are several recommendations regarding specific mechanical ventilation settings, meaning tidal volume per kilo of ideal body weight, PEEP, and the FiO2 in patients with no significant intracranial pressure elevation, or if intracranial pressure is PEEP non-sensitive. And in these cases, the European Society of Intensive Care Meds, with strong recommendation, recommends that in acute brain injury patients who do not have clinically significant ICP elevation, the same level of PEEP should be used as in patients without brain injury. Of course, Also, with patients in acute brain injury who have clinically significant ICP elevation that is PEEP insensitive, the same level of PEEP should be used as in patients without acute brain injury. And finally, mechanically ventilated patients with concurrent acute brain injury and ARDS who do not have clinically significant ICP elevation, a strategy of lung protective mechanical ventilation should be used, all three with strong recommendation. Finally, in mechanically ventilated patients with acute brain injury but without clinically significant ICP elevation, a strategy of lung protective ventilation should be considered. The second group of patients are patients with significant intracranial pressure elevation, and in this patient group, unfortunately, both in patients with acute brain injury who have clinically significant ICP elevation, as well as in patients who have concurrent acute brain injury, ARDS, and clinically significant ICP elevation, there are no currently recommended guidelines on how to use lung protective mechanical ventilation. The second big topic in setting up lung protective mechanical ventilation in acute brain injury patients, besides lung protective ventilation parameters, is of course the question of ventilation and oxygenation targets, or the ventilation and oxygenation goals. And if we look at this study published in 2022 in Critical Care, when they measured oxygen targets and 6 months outcome after out-of-hospital cardiac arrest, we can see that both hypoxemia but also hyperoxemia were independently associated with higher mortality rates. And this is also similar in the recommendation of the European Society of Intensive Care Medicine, where both in patients who do not have clinically significant intracranial pressure elevation and in those who have, the oxygenation targets are the same, meaning normal oxygenation targets between 80 and 120 millimeters of mercury. Regarding CO2 targets, in patients who do not have clinically significant ICP elevation, the target should be normal CO2 ranging between 35 to 45 millimeters of mercury. And hyperventilation is recommended only as a therapeutic option in the case of burn herniation. And regarding hyperventilation as a therapeutic options in patients with clinically significant ICP elevation, there is no currently recommended specific setting. And if we look at the recently published paper for ventilatory targets following brain injury published in Current Opinion Critical Care in 2023, we can see that the PaCO2 targets its normal ventilation targeting the PaCO2 between 35 and 45 millimeters of mercury. Of course, hypocarbia should be avoided due to possibility of vasoconstriction and ischemia, and also hypercapnia that can lead to vasodilation and increased intracranial pressure. And that mild hyperventilation, meaning reducing PaCO2 a bit, can be considered in case of increased intracranial pressure, but prolonged hyperventilation should be avoided in any case. And in some appropriate settings, it can even be considered to raise the CO2 a bit in order to promote specific blood flow, but of course, like I said, it's in specific context. Regarding PaO2 targets, the target is normal oxygenation with avoiding hypoxemia or hyperoxemia. Regarding mechanical ventilation settings, again, it's the classic approach with tidal volume. So if there is no ARDS, we should avoid tidal volumes over 8 milliliters per kilo of ideal body weight. And if we have a patient with concomitant ARDS, we should use the low tidal volume ventilation strategy targeting approximately 6 ml per kilo. And of course, we should mind to avoid dead space as much as possible due to the possibility of CO2 increase. And of course, plateau pressure under 30 centimeters of water and the driving pressure under 15. As for the oxygenation settings, if we have no underlying lung damage, we should use low and moderate PEEP. But if we have a concomitant ARDS, we should of course individualize PEEP, and then of course with ICP monitoring to avoid hyperinflation, we should target the mean arterial pressure over 65 millimeters of mercury and try and promote cerebral venous return, for example, with head elevation and so on. And regarding the FiO2 settings, the target should be classic PaO2 80 to 120 millimeters of mercury. So now that we know what we should do and the guidelines recommending mechanical ventilation settings and oxygenation ventilation targets in acute brain injury with or without ARDS, At the bedside, we only have two real-life options now. The first option is to use initial optimization according to guidelines, and then with manual changes in ventilatory settings whenever needed, which keep in mind mechanical ventilation in acute brain injury and ARDS can be very frequent. The second option that is now available, and what we do in my hospital, is to use automated closed-loop ventilation that is based on guidelines to facilitate 24/7 continuous optimization of both lung mechanics as well as ventilation and oxygenation values in acute brain injury and ARDS. So how can we set up lung protective ventilation at the bedside using closed-loop ventilation? So my bedside tools for 24/7 lung protective ventilation include four major tools. The first one is a quick and safe tool for initial PEEP optimization and recruitment maneuvers when necessary, and for this we use the PV tool, which uses the low-flow PV loop. The second component is the ventilatory mode capable of adapting to patient's condition, meaning compliance, resistance, expiratory time constant, and of course that is able to constantly change between controlled and spontaneous and assisted breathing according to the patient's condition. The third component that I like in lung protective ventilation is continuous adaptation to changes in oxygenation and EtCO2, which is extremely important as we have seen in acute brain injury. And finally, I like to have a safe and intelligent tool to facilitate weaning and spontaneous breathing. Now, all these later three are found in closed-loop ventilation, as we will see in the later slides. So when we talk about ventilatory mode capable of adapting to patient's condition, we in my hospital use the adaptive support ventilation, or the ASV, which is based on the Otis formula of minimum work of breathing and the Meads formula of the minimum force of breathing. In ASV, we use minute volume normalized to ideal body weight, where the ideal body weight is calculated based on the selected patient gender and height, and 100% of minute volume ventilation express the basal ventilation requirements of a specific patient, meaning in adult patients over 30 kilos, it's 100 ml per minute per kilo of ideal body weight, which means, for example, if a patient has an ideal body weight of 75 kilos, 100% of minute ventilation is 7.5 liters per minute. So if we have a patient with 7.5 liters per minute of minute ventilation, we know that this 7.5 liters can be achieved with various combinations of respiratory rate and the tidal volume. Theoretically, you can have respiratory rate of 5 and the tidal volume of 1.5 liters, or you can have a respiratory rate of 15 and the tidal volume was 500 milliliters, or you can have a respiratory rate of 50 and the tidal volume of 150 ml, or combinations giving 7.5 liters per minute of minute ventilation. How can we now know which is the optimal combination of tidal volume and respiratory rate for our patient? Well, we know from basic physiology that for each of the specific lung condition, whether it's normal lung, increased elastic tissue recoil, or increased airflow resistance, there is a respiratory frequency at which the work of breathing is minimal. So if the machine can calculate this, then we will have the optimal respiratory rate at which the work of breathing is minimal, and then we will know which tidal volume is optimal to apply in our patients. So let's see how it works in real life. We select target minute ventilation and the PASV limit, meaning the pressure limit up to which the machine will ventilate the patient. Then the machine will measure compliance, resistance, and the expiratory time constant from the patient, see whether there is any spontaneous activity, and then the ASV algorithm will calculate the optimal combination of target respiratory rate and tidal volume and automatically adjust the mandatory rate and the inspiratory pressure to achieve this combination. And this is all done breath by breath, continuously 24/7. What is important to know about closed-loop control in ASV is that it covers both controlled and spontaneously assisted ventilation and automatically transitions between. Meaning, in controlled ventilation, when there are no spontaneous breaths, the machine will work as a volume-targeted, pressure-controlled ventilation based on the minimum work of breathing and a minimum force of breathing principle. And if spontaneous breaths are detected, the machine will automatically switch to volume-targeted variable pressure support ventilation, again targeting the optimal tidal volume as selected by the ASV. So in terms of safety, ASV has 4 major components to provide lung protective ventilation, meaning it always avoids high tidal volumes and pressures. B, it always avoids low alveolar ventilation, meaning the tidal volume will never drop under 2 times anatomical dead space, meaning 2 times 2.2 ml per kilo. It will always avoid apnea, meaning it will never go with the respiratory rate under 5. And one of the most important features, it will always avoid dynamic hyperinflation, because when it measures the expiratory time constant, and we know that at least 3 expiratory time constants are needed to fully exhale, then the machine knows what is the maximal allowed respiratory rate, and it will never go with the respiratory rate over this. The next component in our individualized lung protective mechanical ventilation is the continuous adaptation to changes in oxygenation and the EtCO2, meaning we want our patient to have stable SpO2 and EtCO2 regardless whether we are at the bedside or not. So how can we do this? We can do this using the so-called intelligent ASV mode. Now the intelligent ASV means that it's now, unlike the manual changes that we have to perform in ASV, either minute ventilation controller, PEEP, the FiO2, or either one of the components is automatically changed by the machine. Either that it's for minute ventilation based on the PEtCO2 and the respiratory rate, or in case of the oxygen and PEEP based on the SpO2 predefined target values. So how do we set up intelligent ASV at the bedside? Well, first of all, we have to select which one of the parameters will be automatized and which one we want to keep manual. Then we can pre-select some patient conditions like ARDS, chronic hypercapnia, or brain injury. If we select none, then the patient is considered normal lung patient. If we use automatic PEEP, then we have to select the upper and the lower PEEP limit in between the which machine can change the PEEP. And one of the most important things are placed on the left side, which is the CO2 elimination and the oxygenation map, in which we can see the targets, and we can make the change in the targets of both EtCO2 and the SpO2. So regarding automatization of ventilation, in controlled ventilation it was quite simple, meaning that you have your current EtCO2 value and you have your preset target EtCO2 zone. And it's quite simple. If your CO2 should rise over your target EtCO2, the minute ventilation will increase. And if your EtCO2 is under your target EtCO2 zone, then the minute ventilation will decrease. And the similar principle works for oxygenation as well. Here you have your current SpO2 value and you have your SpO2 target range. And if your SpO2 value is within your target range, then the machine will maintain FiO2 and PEEP. Of course, depending whether they are both automatized or one is selected as manual selection. If you have an SpO2 that is over target range, the machine will automatically decrease oxygen and or PEEP. If you have a drop in SpO2 but a small one, then the machine will increase oxygen and or PEEP, again depending whether one or both are automatized. And one safety feature, should the SpO2 drop suddenly to very low ranges, then the machine will immediately increase the oxygen to 100%. Now the specifics of brain injury patient condition in intelligent ASV. So if we select brain injury as our patient's condition, then there are 2 major changes within intelligent ASV algorithm. First of all, it will block the automatization of PEEP, so the PEEP will have to be selected manually by the doctor, meaning this is to avoid increase in intracranial pressure. And the second important feature are the changes in the EtCO2 targets and the SpO2 target values. So if we look at our ventilation and oxygenation targets in brain injury mode of intelligent ASV, meaning we select brain injury, now we have manual PEEP, we will see 2 things. First of all, with CO2 elimination, we will see that across wide ranges of peak pressure, the EtCO2 is remained constant and within really narrow ranges, meaning as soon as its CO2 changes even a little bit, the machine will either increase minute ventilation or decrease minute ventilation, having a really tight and strict ATCO2 control. And the same thing applies for oxygenation, meaning regardless of the PEEP level, there will be no permissive hypoxia, meaning the patient's SpO2 range will be kept in tight ranges with higher values than what we would use, for example, in classic ARDS without acute brain injury. And this is practically 100% in line with the recommendations we saw before from the recent studies. Of course, what we know is that sometimes due to specific lung conditions, we can have an increase in the PaCO2 to EtCO2 critical gradients. So what we can do, we can take the blood gas analysis, we can see the PaCO2 and the EtCO2 gradient, and if we need to change the EtCO2 targets, we can switch it either to higher or lower EtCO2 depending on the PaCO2 values. But if we look at the study by Jean-Michel and Arlo in 100 patients ventilated with dilated ASV, we can see that this alveolar to arterial EtCO2 gradient is quite stable in all patients' condition, always practically under 10 millimeters of mercury, even in severe COPD. So there are still a lot of studies on clinical use of intelligent ASV in acute brain injury, but there's this nice study by Ananev in 2017. So what this group did, they took 12 patients with GCS 4 to 9, included under 72 hours of the traumatic brain injury. They used only hemodynamically stable patients, and they interchanged intelligent ASV and PCMV with 12 hours each in each patient, and they targeted the same PaCO2s, meaning 35 to 38 millimeters of mercury in both groups. They took blood gas analysis at start and every 3 hours. And in PCMV group, the readjustment of inspiratory pressure and respiratory rate was done when PCO2 was out of range. And in intelligent ASV group, there was the readjustment of the EtCO2 target when PaCO2 was out of range with the maximum right shift of the SpO2 target. So if we take a look at the results of the study, we can see that the median values in both groups were relatively stable. But two things were noticed. First of all, if you take a look at the number of measurements, the PaCO2 values were off, either too low or too high. It's far less in the intelligent ASV group than in the PCMV group, meaning the number of measurements within exactly desired range in intelligent group was higher. And if we take a look at the mean frequency of manual adjustments that had to be done, we can see that in the intelligent ASV group there had to practically be no adjustments done within the 12 hours period, unlike in the PCMV group where they had to make a lot of adjustments. So in conclusion, in their study, intelligent ASV mode provided a narrower target range of PaCO2 in patients with traumatic brain injury while reducing the need for manual settings of ventilator parameters, and this therefore reduced the workload of the medical personnel, which is extremely important in modern times when we know that the medical personnel is lacking all around. So in conclusion, I would like to say that I think we all know that mechanical ventilation in brain injury patients is difficult due to complexity of brain-lung interactions, and in some cases due to different ventilation and oxygenation targets and strategies for both brain and lung protection. On the other hand, closed-loop ventilation using intelligent ASV delivers breath-by-breath lung protective ventilation with, if the brain injury mode is enabled, tight control of both EtCO2 and the SpO2 24/7, while in the end reducing the workload of both doctors and nurses. And so as we say that the art of life is a constant readjustment to our surroundings, it's the same way that the intelligent ASV constantly adapts to our specific patient's condition, trying to provide lung protective ventilation breath by breath 24/7, regardless of the patient's clinical condition. So thank you very much for your attention, and goodbye from Croatia.